From the JAMA Network, this is JAMA Oncology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Oncology.
Welcome to JAMA Oncology Podcast. I'm Vivek, Subbiah, medical oncologist, early phase drug developer, and chief of early phase drug development at Sarah Kennedy Research Institute, Nashville, Tennessee. And I'm also the web editor for JAMA Oncology. Today, it is my pleasure and honor to have Dr. Maria Cabanillas. Hello, Dr. Cabanillas. Do you want to go ahead and introduce yourself?
Hello, Dr. Subbiah. Yes, I'm Maria Cabanillas. I am an oncologic endocrinologist at MD Anderson Cancer Center in Houston, and I treat primarily thyroid cancer and specialize in advanced thyroid cancer treatments with immunotherapy and targeted therapies.
Thank you so much. It's a pleasure and honor having you here. So to all our listeners, today I want to share something very close to my heart. As a global principal investigator, I had the privilege to lead the ROAR basket study, the Rare Oncology Agnostic Research Study with BRAF and MEK combination of dabrafenib and trametinib in BRAF V600 positive cancers that led to the tissue agnostic approval of BRAF and MEK combination in BRAF positive solid tumors in 2022. I had the extreme honor of working with Dr. Maria Cabanillas and other global investigators that led to a groundbreaking FDA approval for BRAF plus MEK combination targeted therapy as one of the first cohorts in anaplastic thyroid cancer. To our broad listeners here, what is anaplastic thyroid cancer? Anaplastic thyroid cancer is one of the most aggressive cancers known to us. The historical median overall survival for this deadly disease was a mere 5 months before this approval. Its rapid growth often causes severe complications like respiratory distress and difficulty in swallowing. Delayed diagnosis is common due to its rarity, and by the time it's detected, the disease is usually inoperable and has often metastasized. However, among the various mutations that drive these deadly tumors, BRAF V600 mutation stands out. This actionable mutation paved the way for the FDA approval in 2018 of a specific combination therapy using dabrafenib, a BRAF inhibitor, trametinib, a MEK inhibitor. This therapy was specifically for patients with BRAF V600E mutated anaplastic thyroid cancer, which constitute approximately 35 to 40% of cases. Unfortunately, for patients with non-BRAF mutated anaplastic thyroid cancer, there are still no approved effective therapies. Clinical trials with single-agent targeted therapies have shown limited success. In this issue of JAMA Oncology, Dr. Maria Cabanillas and the team from the Rare Tumor Initiative have led this remarkable study of anti-PD-1 plus targeted therapy in anaplastic thyroid cancer. It is a pleasure to have Dr. Cabanillas talking about this. Dr. Cabanillas, can you talk about this publication in your own words for our JAMA Oncology listeners?
Yes, thank you for that introduction. It was wonderful. This is a very difficult tumor to treat, and so we face many challenges. One is that it's a rare tumor, and it's an extremely fast-growing cancer. It's probably the most deadly cancer in humans, and therefore we needed to develop a trial that would match those characteristics so that we are able to treat patients effectively. So we designed this phase 2 non-randomized clinical trial. It was mutation matched because only 40% of anaplastic thyroid cancer patients have a BRAF mutation, leaving 60% of patients without effective therapy. The other observation that we made in anaplastic thyroid cancer is that although targeted therapy with BRAF MEK inhibitor worked very, very well in BRAF mutated anaplastic thyroid cancer, patients eventually all progressed. And the reasons that they progress are not completely understood, but we do know that they develop bypass mutations. And therefore, we wanted a strategy that could possibly help with these clones that maybe are not being targeted with the BRAF/MEK inhibitor. The other observation was that targeted therapy seemed to work very, very quickly, whereas we know that checkpoint inhibitors take a long time to start to shrink tumors. And so we needed something that would match the speed of the disease, i.e. targeted therapy, and then try and delay or avoid resistance. Therefore, this was a matched trial, it was a mutation matched trial. Patients received a targeted therapy matching their mutation, and then all of them received the checkpoint inhibitor atezolizumab. Cohort 1 consisted of patients with BRAF V600E mutations, and those patients received the targeted therapy vemurafenib cobimetinib. This is a BRAF/MEK inhibitor. In cohort 2, we had RAS mutated and NF mutated patients, and those patients received cobimetinib as their targeted therapy. And then in the third cohort, it was patients that didn't have any of these mutations or didn't qualify for another cohort, and those patients received bevacizumab, which is an intravenous drug that inhibits VEGF. And again, all patients received atezolizumab. So the way that we did this, I believe, is very novel. Nobody had really done that in anaplastic thyroid cancer. And the other reason that we made it a single arm study, though, is just because it's a rare disease. Very difficult to enroll these patients because they get very sick very quickly.
Thank you so much, Dr. Cabanillas, for the broad overview. So you mentioned that this was a non-randomized study design. Our listeners are used to reading a randomized study design. So how did you ensure that the non-randomized design of this study did not introduce significant selection bias? And what measures were taken to control for potential confounding variables? Because this is a lesson not just for anaplastic thyroid cancer, which is a rare disease, for many other rare cancers as well.
Yes, so what we did is that we designed a study that we could put the majority of our patients on, so that, for example, we didn't have to have a patient that was able to swallow pills, which many times anaplastic patients could not, because we wanted it to be a real life study. We wanted patients who could not swallow to be able to participate. We wanted patients that could swallow to be able to participate. We wanted patients with other comorbidities, history of cancer, which oftentimes you don't see in oncology trials because we know that anaplastic thyroid cancer patients tend to have history of other cancers. And so we really tried to broaden the usual oncology entry criteria and be the most inclusive possible so that when we attempt to use these drugs in the real life setting, that we would actually see that the trial results match the real life results. I wish that we could have done a randomized trial. The problem with doing randomized trials in anaplastic thyroid cancer is that these patients, first of all, as I said, it's a rare tumor and they're often very, very sick very, very quickly. But also patients will almost uniformly ask us if they're being randomized to any type of placebo, and that is a deal breaker because these patients know that the first treatment that they receive is really the most important. It is going to dictate their overall outcome. So you really have to get it right the first time. I do think that in the future, it's possible to do a randomized trial. However, it will be very difficult to do that in one institution. You would have to have global enrollment for this, especially enrollment outside of the United States, where patients really cannot obtain these immunotherapies because they're considered off-label.
So you selected efficacious combination therapies. Of course, the vemurafenib and cobimetinib arm is for the BRAF V600E alteration. What is the rationale behind cobimetinib for the RAS or NF2 mutations, and why was bevacizumab chosen for the non-BRAF, non-RAS, and non-NF mutations?
So the easy answer to that is that this was a Genentech alliance, and those were the drugs that were available. Now, using the cobimetinib, which is a quite a potent MEK inhibitor, as you know, made some sense to use in RAS-mutated NF tumors at the time. Now we have probably better ways of inhibiting that pathway, but at the time, this is what we had. In addition, these patients tend to have a very high risk of bleeding, of carotid blowouts, bleeding from tracheostomies. They can have a very high risk of TE fistulas. And therefore, we wanted a drug that was not a very potent anti-angiogenic to utilize in these patients because we felt it was safer. And therefore, a MEK inhibitor was a reasonable strategy. The bevacizumab was a wonderful, it didn't work out well in cohort 3 with bevacizumab tazolizumab. However, it was, in my mind, a wonderful drug to use because it was intravenous. Now, these patients have a very hard time swallowing oftentimes, and therefore it seemed like a great solution. However, we don't think that bevacizumab was really potent enough anti-angiogenic to be sufficiently efficacious in anaplastic thyroid cancer.
Well, thank you so much. So you mentioned about the adverse events and management, right? So for the broad listeners of JAMA Oncology, what specific strategies were implemented to manage the serious adverse events like colonic perforation, left ventricular dysfunction, and were there any long-term follow-up protocols to monitor these patients?
Yes, so adverse events are difficult in anaplastic thyroid cancer. Obviously, you have to stop the drug, and that usually is detrimental to many patients. However, we had what I call the backup drug of the checkpoint inhibitor on board. The adverse events that we saw, some of them were probably related to the BRAF MEK inhibitor or MEK inhibitor, such as left ventricular ejection decrease. And that actually recovered off the MEK inhibitor in that particular patient. Colonic perforation is something that we unfortunately see a lot with anti-angiogenic drugs. Interestingly, that actually occurred in cohort 1 and cohort 2. It may have been attributed to the BRAF inhibitor in cohort 1, which we do have reports of perforation in those patients, or the immunotherapy, which we also see can cause colonic perforation. One patient actually died of colonic perforation, unfortunately, and that was a serious and terrible outcome for that patient. The patient was elderly and did not want to go to surgery, but it was something that we would have, in a healthier patient, taken the patient to surgery to try and resolve that adverse event. Pneumonitis, other things that were related to the immunotherapy were things that were seen. We treated, of course, with steroids, and that really turned around the pneumonitis. So we were monitoring these patients very closely, Vivek, and we were able to catch these things because we were doing echocardiograms on our patients. We were, of course, imaging them and following their symptoms, and we have a great team at MD Anderson, ancillary services such as pulmonary medicine and the GI teams that helped us a lot with the colitis. With the colitis, I do want to point out that we used drugs that were just targeted to the colon to decrease the inflammation, which didn't give us the systemic effects of the steroids that are often used with colitis. And so all of these teams at MD Anderson really helped us manage those side effects. But I think catching these things early is critical, particularly for patients on immunotherapy.
So the study allowed patients to continue treatment past progression if deemed beneficial by the treating physician. Again, in many of the investigator-initiated studies, I strongly recommend all the faculty who are designing the studies to include this. But our readers may not be aware of this criteria to allow treatment past progression. Could you provide more details on the criteria you used to make in this study to make this determination and how it might have impacted the study results?
Sure. I think many immunotherapy studies these days allow to continue the treatment past progression. We allowed the treating physician to determine that if the patient should continue in the conjunction with other team members like myself to determine whether it was safe to continue therapy. And it wasn't that we continued the therapy indefinitely. It was a way for us to try and figure out what to do about the progression in these patients. So, for example, sometimes we see patients are starting to progress in one area, and we're able to either resect the area or we're able to radiate, and that gave us enough time to bridge that patient to that therapy, or to determine what the next therapy should look like and allow us to order those therapies for the patients and get approval for them. Because what we know in anaplastic thyroid cancer and in very aggressive advanced thyroid cancers is that if you abruptly stop the therapy, these patients will rapidly progress and often die of their disease very quickly. And therefore, we try and maintain the patients on therapy long enough for us to be able to figure out what the next step should be. Because these patients can live a long time past progression. And another interesting observation that we've made in our patients is that patients who are exposed to immunotherapy tend to live a lot longer. And it's not understood why that is. However, we do know that the longer they're exposed to immunotherapy, they also have more adverse events. So it's a balancing act here. But we do see that patients benefit by staying on the trial a little bit longer until we can sort out what to do next.
The study mentions that several patients' tumors became resectable following the combination therapy. Can you discuss the criteria used to determine the resectability and the role of surgery in improving overall survival in these cases? We talk about targeted therapy, but for solid tumors, surgery is the ultimate targeted therapy. It'd be great if you can, talk about this to our broad audience.
Right. So what we found in the trial is that 12 of the patients, their tumors became small enough to be able to remove them. And all of these patients except one went to surgery. The patients in cohort 1 were the majority of the patients that we were able to resect their tumor in their neck. And that was 9 patients. In cohort 2, there were 2 patients that became resectable. At the time of publication, 73% of those patients were still alive. And what's really interesting is that 72% of those patients were also patients who had metastatic disease at diagnosis. So they were stage 4C patients. So as with some other cancers, we do see that removing the primary tumors seems to give these patients a survival advantage. And so we believe that the best strategy now is, especially in the BRAF mutated population, is to use these therapies as neoadjuvant. And we're doing clinical trial to show that now, that these patients do become resectable. We don't know if that increases their survivability. However, if you compare the outcomes of the ROAR trial, which was the dabrafenib plus trametinib trial that led to the approval of those drugs in BRAF mutated ATC, the median overall survival was about 14 months. And in our patients, the median overall survival in cohort 1 was 3.5 years. So there does seem to be, this different patients, right? There's different patient populations in these studies, but this is a 2-year advantage, either from immunotherapy or because we resected many of these patients. It's unclear. But now we do recommend upfront neoadjuvant therapy in the BRAF mutated patients for that reason.
In conclusion, based on your findings, what are the next steps in research for non-BRAF mutated anaplastic thyroid cancer? And how do you envision integrating newer targeted treatment currently in clinical trials into future studies?
For non-BRAF mutated patients, we still have a lot of work to do. We are doing some of that work currently. There are trials with lenvatinib pembrolizumab that are ongoing, one in Germany, one at our site. We're also designing other trials with palliative doses of radiation, so lower doses of radiation, between 14 and 30 gray to the primary tumor, followed by immunotherapy and the targeted therapy, in this case, a VEGF receptor inhibitor. And we're really looking at synergism of these drugs and these modalities, because we know that there's not one treatment that's going to cure anaplastic thyroid cancer. This is multimodal therapy. We use everything in our tool chest that works for anaplastic, so radiation, we use surgery, we use immunotherapy, and we use targeted therapy. And so we do think that that is the way to go in anaplastic thyroid cancer, so we're starting to study this in a prospective clinical trial. Again, single-arm study, because these studies with randomization are very difficult to do in a rare patient population.
Thank you so much, Maria, and congratulations on the publication of the paper. I am Vivek Subbiah, and I've been speaking with Dr. Maria Cabanillas about anti-PD-L1 plus targeted therapies in anaplastic thyroid carcinoma. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Musisi at the JAMA Network. Thank you so much for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.